he was a sleep fellow 4 years ago and then became a pulmonary fellow. And he's gonna talk to us about breathless nights, OSA and obstructive lung disease.
Yes, thank you so much. I wanted, I guess, 8:05, we should get it going.
Yeah.
So yeah, just I know there's a lot of familiar, faces on the Zoom, but good to see everybody again and talk a little bit about the overlap of pulmonary and sleep medicine. I have nothing to disclose. The only disclosure I have is I have some pictures of my very cute 16-month-old daughter at the end. So if that's a bribe to stick with it, then so be it. But so the point of the talk is really, this is, I think, patients with both obstructive lung disease and sleep disordered breathing seem to be unique in their severity of disease. And I think historically it's been, I think maybe pulmonary medicine providers and sleep medicine providers are sort of like left with, who should sort of primarily be the quarterback, so to speak, for these patients. So I think it helps to kind of, for all of us and for those in sleep medicine, to have an understanding of, these are common issues we encounter with patients with sleep apnea. So I'm kind of wanted to talk about some of the epidemiology, talk about how some of the physiology may explain some of these, comorbid conditions and why they seem to co-occur and why they seem to be worse together. And then think about that and how that might help us evaluate and manage these patients. So just, why obstructive lung disease, why things like COPD and asthma? Well, I don't think anybody in pulmonary medicine would disagree. These are kind of our bread and butter. I mean, in terms of general pulmonary clinic, asthma and COPD are sort of, amongst the top chronic lung diseases that we see. Worldwide, we could include, pulmonary fibrosis and occupational lung disease. But, for the average pulmonologist, this is a lot of what they see. And just, for our audience here, like there's certainly overlap between these diseases. I mean, their functional outcome is they're both cause obstructive lung physiology, but just in terms of kind of a reintroduction to sort of what seem the subtle differences. So asthma is, really a disease of airway inflammation. It's usually onset in young people, but can be later in life as well. The history is really of respiratory symptoms, dyspnea, cough, and wheezing that vary over time. And there's variable expiratory flow limitation, as opposed to COPD, which is more sort of a persistent progressive airflow limitation. Generally, it's older people, and generally there's an exposure to a risk factor. Here in the US, that's obviously tobacco smoke, but worldwide, it's biomass fuels can include, smoke, the fires burning in the home and smog and things like that. So what's the sort of burden of disease in terms of sleep apnea in things like asthma or COPD? Well, obviously, we know sleep apnea in general is incredibly common. So for these common diseases, we would expect, at least rates similar to the population. We think probably upwards of 20+ million people in the United States have sleep apnea. However, we think that there's probably an increased risk of sleep apnea in patients with asthma as well. So actually I pulled up this paper. This is from Dr. Ockley, Ziad Shaman a few years ago. They administered the Berlin questionnaire to both patients from an asthma clinic and patients from an internal medicine clinic, and found increased rates of sleep disorder breathing symptoms in the asthma population. And that was really despite similar comorbidities, similar, BMI, similar rates of hypertension, and it really seemed to be independent of asthma severity. And then on the right here is another retrospective cohort study in Taiwan, compared an asthma population to a matched control population matched for gender and age. And as you can see, over time, followed over years, there's a significant increase in the incidence of of sleep apnea in the patients with asthma as opposed to the patients without. A 2.5-fold increase in incidence. In addition, the risk for sleep apnea seems increased even more in poorly controlled asthma. So this is from Mihaela Teodorescu. She's at the University of Wisconsin, done a lot of research in the sort of overlap of asthma and sleep apnea. So this study of hers, she had 752 asthma patients sort of pooled together from a couple tertiary care centers. They administered the sleep apnea scale of the sleep disorders questionnaire and an asthma questionnaire, and showed that both patients at high risk based on the questionnaire, as well as patients with the diagnosis of sleep apnea, were much more likely to have persistent daytime and nighttime asthma symptoms. So sort of suggesting that poorly controlled patients seem to be have even higher risk and have even higher prevalence of sleep apnea. Now, in terms of COPD, the relationship is a little less clear. So in the first study on the left, this was a sort of a secondary analysis of the sleep heart health study, looking at spirometric data from those, thousands of patients. So they sort of group people into those with obstruction on spirometry, and that's their definition is an FEV1 to FVC ratio greater or less than 70%. And they didn't really see any significant difference in the RDI between those patients, or the percentage of patients who seem to have, mild versus moderate versus severe sleep apnea. And then on the right, this is a secondary analysis of the Mr. Oz study, so another large population-based study, using a couple different definitions of spirometric definitions of COPD, and overall showed either equal or lower rates of sleep apnea in that population as a whole. So one question would be, well, patients with COPD, can have pulmonary cachexia, can have lower BMI. So does that explain the lack of association in terms of COPD and obstructive sleep apnea? And it doesn't necessarily seem like that, because in that same study, looking at the sleep heart health study, they broke down the patients in terms of their BMI quartiles, and saw that still there wasn't really any significant difference. So even the obese, patients with the obstruction still didn't really seem to have higher rates. So suggesting, BMI alone was not an explanation for the lack of association. So, okay, they are comorbid, and the association is clear with asthma, maybe less with COPD, but what's the impact clinically? Well, it's significant, especially in asthma. So, untreated sleep apnea and asthma is associated with a variety of untoward outcomes. So on the left here is a study showing, a significant relationship with in an asthma population with the patients' AHI and the rates of severe asthma exacerbations. And on the right, this was sort of a prospective cohort study looking at the FEV1 decline per year in patients with sleep apnea and asthma, and showed that the more severe the sleep apnea, the higher the rate of decline of FEV1. So suggesting that there is clearly some effects on asthma outcomes as a result of sleep apnea alone. In terms of COPD, I think it's actually even a little more concerning. So, two studies here looking at patients with both COPD and obstructive sleep apnea, and essentially trying to decipher whether they're treated or not. So on the left, looking at a prospective study, looking at patients and they're stratified by their hours of CPAP usage, and that line on the bottom there is a 0 to 2. So the patients who were less likely and didn't or barely use CPAP with COPD, they were more likely to die in the period of observation. And on the right, this is the overlap study from the Blue Journal in 2010, showing similar rates of mortality with patients with COPD when treated with CPAP if they have comorbid sleep apnea, but for those untreated, significant decline in survival rates, and as well as exacerbation-free survival on the bottom. So both mortality and exacerbation seem to be increased in that untreated comorbid group. And it's not just in terms of OSA and COPD, it's more than just clinical outcomes. We see actually worse pulmonary mechanics and gas exchange. So this study from the Blue Journal a few years ago, 1995, but compared basically patients with COPD, patients with sleep apnea, and patients with sort of both syndromes, and showed that the patients with both had a variety of poor markers, including lower FEV1, sort of lower FEV1 to FVC ratio, kind of suggesting worsening obstruction, higher airway resistance, as well as changes in gas exchange. So they had lower resting oxygen content and higher resting carbon dioxide content. Again, in that overlap group compared to either group alone. And then similarly, in OSA and COPD, those differences were there despite pretty similar or essentially identical rate, BMI, and really no significant differences in the burden of sleep apnea, similar AHI, similar time in apnea. So again, just without worsening sleep parameters, they still have a lot of poor markers of their disease process. So, but from these kind of epidemiologic stuff, the question is, well, what's the main driver of these outcomes? Is sleep apnea having a direct effect on their airway mechanics? Is there increased airway or systemic inflammation? And then what about the confounders? Again, BMI between these patients. What about their comorbidities? Are the sicker patients just sicker in general? And then the question is, yes, there are differences between COPD and asthma, but they're both obstructive lung disease. But why this stark difference in terms of incidence and outcomes? So those questions still remain. So, just to sort of think about, well, why is this happening? Just sort of reviewing a little bit of physiology to see, if that can help us answer the question. So obviously we know there's normal ventilatory changes during sleep. There's decrease in the central drive and chemoreceptor sensitivity. Obviously the changes in respiratory muscle activity and respiratory mechanics. And these are normal. These are normal changes that occur in everybody. What about patients with obstructive lung disease? So this was an interesting study from about 10 years ago. They took 5 male asthma patients, and put them in this interesting device where they were measuring a lot of things, including expiratory, in terms of flow. They were measuring esophageal pressure, and they were sort of in a spirometer box to be able to basically measure ventilatory changes during sleep in these patients. What they found was that, for the asthma patients in this study, compared to sort of historical controls, patients with asthma had much higher airway resistance, at the same lung volume. And they seemed to have worsening compliance, as they went from upright to supine to sleep. Here they call early sleep and late sleep was sort of interesting definitions. Early sleep was just sort of right after they fell asleep based on EEG, and late sleep was 3.5 hours in. But showing that, they have worsened airway mechanics, during sleep, regardless of sleep apnea presence, compared to sort of healthy controls. And so the effects of that are essentially that they have worsening air trapping during sleep and decreased peak flow compared to healthy controls, these patients with asthma. In addition, there are circadian hormonal changes that occur in all of us, but there does seem to be difference in patients with asthma versus normal controls. So on the right here, just looking at ACTH and cortisol levels in patients without asthma, with patients with asthma but not nighttime symptoms, and patients with both asthma and nocturnal symptoms showed different levels of ACTH and cortisol, and different spikes in terms of their plasma histamine, epinephrine, et cetera. So suggesting that circadian difference in peak flow could be explained possibly by altered hormonal changes. That's asthma. So what about COPD? So similar study here, sort of looking at a population of patients with COPD and chronic hypercapnic respiratory failure, trying to understand, what is the etiology or what is the explanation for some of their ventilatory changes. So similarly measured, flow, EMG, esophageal pressure, gastric pressure, and transdiaphragmatic pressure in a small population. And showed that, there's the one clear difference is an increase in the upper airway resistance in these patients, and what seems to be a significant change in the set point of their ventilatory hemostasis. So suggesting, there's a central component to the changes in ventilation in these patients with COPD. So when you combine all that, you know, these patients with asthma or COPDs, patients with obstructive lung disease, you know, they have ventilatory changes during sleep as well, but they seem to be, you know, significantly worse in certain areas. So, you know, the risk factors for chronic hypoventilation, you know, significantly decrease their chemoreceptor sensitivity and can reduce their central drive. Some of these patients already are using accessory muscles of respiration during the day to sort of maintain adequate ventilation, and at night, that compensation is lost. In addition, they have a worsening respiratory mechanics compared to normal patients, so they have increased airway resistance, increased ventilation perfusion mismatch. So, you know, compared to normal controls, these patients with obstructive lung disease can really struggle at night. That might explain some of these issues. So I just like the sort of graph and how to think about it, that, you know, normally, right, we have a respiratory load and a respiratory muscle capacity. So that's sort of that top left panel there, you know, nice balance there. But patients with these lung diseases, they have an increased respiratory load. And so their sort of reserve is lower. And so once they go to sleep and the respiratory muscle capacity has been lost, now all of a sudden you have this mismatch and this imbalance, and that's where things like non-invasive ventilation or positive pressure might help. But basically, I think it's a nice way to think about, you know, why these patients could struggle even more. And again, we know that a lot of chronic respiratory failure and awake hypoventilation, you know, certainly sleep. Ventilation during sleep affects that. So just this little, you know, experimental study just showing that even in patients without, you know, steady chronic respiratory failure, just significant burden of apneas and periodic breathing at night alone can over time lead to chronic respiratory failure and decreased ventilatory response.
That's a really interesting study.
Yeah, you know, I mean, now this is a computer model, and so, you know,
They tested it.
yeah, and so, but just
during sleep was going on as well.
right, exactly. So, and this is sort of a study without, you know, it's really just testing sleep apnea, like a significant sleep apnea. So you imagine if you add, you know, other risk factors and abnormal airways with lung disease, that this could get even worse. And again, so this is this cycle, you know, that can occur is just the risk factors patients have, some burden of sleep apnea, their inability to compensate, and you get this cycle of, you know, hypoventilation during sleep, compensatory response, blunted ventilatory response, and you can just kind of cycle into chronic respiratory failure. So, you know, there's lots of interactions here in terms of obstructive lung disease and sleep apnea. You know, in terms of asthma and sleep apnea, we know that there's a lot of associations in terms of comorbidities, including rhinitis and reflux, and obesity. The idea is, you know, obstructive sleep apnea can cause intermittent hypoxia and imbalance in sort of the inflammatory responses in the lungs, and that itself can affect central respiration. And so you can imagine again the cycle of how maybe sleep apnea might directly contribute to worsening disease in patients with asthma. And COPD is a similar issue. There's certainly some protective factors in terms of COPD, which is mainly the lower BMI than average. But there's still the same issue of hypoxia, oxidative stress, and systemic inflammation that puts these patients at risk for untoward outcomes. So, what about positive airway pressure? What do we know about the effects of positive airway pressure in patients with obstructive lung disease? Well, the idea is that you know, one of the pathophysiologic mechanisms in patients with obstructive lung disease is what we call sort of intrinsic or autopy and dynamic airway collapse. So the idea is that sort of on the left there is sort of a normal airway. However, in patients with COPD or asthma, sort of the second or third columns there, you know, those airways at low lung volumes collapse sooner than they do for average healthy control. So the idea is that, you know, positive airway pressure, or here they're calling it PEEP, can help stent open those airways that would normally collapse at those low lung volumes, and presumably, ensure, good emptying, and of air for those patients. We know that, and this is a study for patients on who are mechanically ventilated with COPD, but that treating that auto or intrinsic PEEP with positive airway pressure does decrease work of breathing. Essentially, in terms of the patient's effort, they have less work to overcome when that auto PEEP is treated with positive pressure. And so the idea is over time, if you treat that auto or intrinsic PEEP, you can decrease hyperinflation in these patients and then decrease the respiratory load. So in terms of, patients with COPD on positive airway pressure, it's not just a theoretical. Here is a sort of a group of about 10 patients from a study about 25 years ago. Patients applied with COPD applied PAP with comorbid OSA showed a bunch of improvements in obviously their hypoxemic parameters and their AHI, but also improvements in airway mechanics. So in terms of baseline and 1 month follow-up, increases in FEV1, slight increases in FEC, increases in resting oxygen and decreases in resting carbon dioxide levels. So suggesting, that just the application of positive airway pressure and CPAP can improve not just obstructive events in these patients, but also the pulmonary mechanics and gas exchange.
While awake.
Another area here is obviously, especially with asthma, a lot of concern for comorbid acid reflux, complicating things. However, we know that in general, CPAP and reflux, CPAP can help reflux for a variety of reasons, basically including increasing the barrier pressure on the esophagus and decreasing the lower esophageal opening time. So even though sort of, I think maybe historically been taught that CPAP the thought is maybe it stents open or increases risk of reflux, seems to actually have the opposite effect. So that might also be one of the mechanisms for its benefit. So again, then what's the clinical impact of positive airway pressure in these patients, knowing that there's sort of these experimental, theoretical positives? Well, certainly patients with asthma and sleep apnea who are on positive airway pressure seem to do better. So this is a group, of patients, about 100 patients initiated on CPAP for sleep apnea and had the asthma control questionnaire, the ACQ, measured, and sort of showed at a 3-month and 6-month follow-up that we had decreases in the poorly controlled responses. In addition, the patients seem to have lower rates of reported heartburn, regurgitation. They even seem to also have the improvements in lung mechanics. So in terms of their spirometry, fewer of those patients had a positive bronchodilator response, so suggesting decreased bronchial hyperresponsiveness, and FeNO, which is just another marker of airway inflammation. So suggesting, again, beyond just treating the sleep apnea, there was other sort of effects of the positive airway pressure in these patients.
It's expired nitric oxide.
Yeah. In terms of just another study, just looking at another population, severity of asthma, before and after initiation of CPAP, just again, sort of across the board, significant improvements in both their severity of asthma, sort of on a visual analog scale based on the patients, as well as the validated questionnaire, the ACT, the asthma control test. So what about COPD and sleep apnea on positive airway pressure? Well, on the right is the same study I showed earlier. So obviously we know that the patients in that study who had overlap of COPD and sleep apnea who were treated with CPAP, they had similar rates of mortality and exacerbation-free survival compared to the patients who were not treated. And then on the left was another study sort of showing prospective study looking over about 100 months, again, patients were on long-term oxygen therapy and initiated on CPAP for sleep apnea. Those who were using versus not had higher rates of survival over a 100-month period. And in terms of other effects, it's not just those hard outcomes in COPD and sleep apnea. This is a study just a couple of years ago, looking at patients with COPD and sleep apnea sort of at a time zero, year 1 and year 2. And those who were initiated on PAP, they had a lot of significant benefit, including decreased ER visits, decreased hospitalizations for COPD, and decreased sort of overall cost or utilization to the healthcare system. And that's both for and only in the adherent patients. So again, it's not just being initiated, but it's also using it. So there's lots of evidence here of benefit in these patients, but the question still remains is like, what is the exact mechanism? How much of it is treating their underlying sleep apnea and reducing their obstructive events? Is it improving their sleep quality and their consolidation of sleep? How much of it is this direct benefit of positive airway pressure on these abnormal airway mechanics? So, clearly there seems to be benefit, but exactly what's doing the most is not clear. One question again is auto CPAP, which is our most commonly prescribed sort of modality, the best for these patients? They have abnormal airways, they can have, different responses to positive airway pressure. So is auto CPAP okay for these patients? Do they need separate or different modes? Can these algorithms be tweaked for obstructive airway physiology? Like, are they able to handle that kind of change in flow? So that remains to be seen. And then what about non-PAP treatment? So would these patients benefit from things like an oral appliance? And is that good enough to treat? Will they see the same benefits? So those are some remaining questions. Ultimately, I think that this is really an area that I think, deserves a lot more follow-up and a lot more thought, because, in terms of the approach to these patients, I think it's still kind of remains to be seen what's the best way to do things. Obviously, there's an importance of screening. So I think for the most part, I think more patients with sleep apnea and lung disease sort of make their way out of pulmonary clinics without identifying their comorbid sleep disorder breathing rather than the other way around. So in terms of reaching out to, pulmonary physicians and pulmonary providers to make, screening and increase awareness of sleep disorder breathing, I think is important, because we know that a lot of these patients are coming in and out of pulmonary clinics without even being asked about their sleep symptoms. So, we need to treat their underlying lung disease and maximize their medical therapy there. So whether that's, the right inhaled therapies, reducing risk factors like cigarette smoking, reflux, rhinitis, things like that. We need to not just treat their sleep disorder breathing, but also their other comorbidities and maximize therapy for their underlying lung disease. These patients can have complex physiology as we've seen in airway mechanics and risk for chronic respiratory failure. So, if in doubt, these patients might be better suited for, in lab testing and titration rather than home sleep testing alone. Not to say it can't be done, but certainly they're at higher risk for having complex physiology that might not be captured on home sleep testing and auto titration at home. And close follow-up. So obviously, for these patients, diagnosing their sleep apnea is not the only chore. It's also getting treatment and making sure that treatment's being used, because we know, sort of low or under treatment is also putting these patients at risk for all these outcomes. And ultimately, this is, I think, an area where we need to have, strong pulmonary and sleep partnerships. So this is, where communication between providers is really important. And, these patients can be complex, and doing the best for them, would involve, good communication between pulmonary and sleep providers. So my take home points, you know, again, asthma, COPD and sleep apnea, they share complex pathophysiologic mechanisms and risk factors. Finding these patients and treating them, we think should be expected to improve a variety of patient-centered outcomes. But ultimately, these patients have multiple disease processes at the same time, and the approach is multidisciplinary and requires sort of these partnerships between pulmonary and sleep. So I know a bit of a shorter presentation, but just want to thank you all just for again, those of you when I finished up sleep fellowship, this is actually me and my wife on the left. That was matched when I matched in the pulmonary critical care fellowship. So last May we had our daughter Aria, and she makes us very proud. She's already she's a multi-sport athlete. She's a she's a food critic, and this is actually her on the right when I was working on this presentation. So she's giving me some harsh notes there, but just wanted to share that with you all since I haven't seen a lot of you in a few years. So thank you so much for taking the time to listen to my talk today. These are the references I have for the articles I brought up, and I appreciate your time and would be happy to answer any questions.